It kind of got to a really dark place where I felt alone and there was no one even around to be able to help anything.
By the time I was 24 is when something clicked. Something snapped inside of me and I started to be able to find that freedom that I was looking for on the inside.
October 18th, 2012 is when my recovery began.
Our role as a society, as a community, and clinicians is to help them enter that pathway.
One thing I always tell my patients is that treatment is out there and treatment is effective.
So the goal of treatment is to achieve a remission of the disease, which means the symptoms subside. But in a bigger picture, the goal of addiction treatment is also to achieve a recovery from addiction. It doesn't mean that addiction doesn't exist, but addiction is really well managed and doesn't impact this person's life. The person has control over their life.
There are many different ways to really attack this problem, and the mainstay has mostly been in therapy, be it group or individual, or 12-step programs, very popular. All of them are great. They're each very effective. The most effective, however, is medication-assisted treatment. These patients can benefit from medications that make them live normal, healthy lives.
Medication-assisted treatment is probably a very logical step. So in addition to referring you to the right place, I'm going to bridge you until you can get in, get that follow-up, get the treatment, get long-term care that you need. My name is Mike Lohmeyer. I'm an emergency medicine physician at the Burby Walsh Department of Emergency Medicine at the University of Wisconsin. I'm also the Dane County EMS Medical Director, and I'm a member of the Safe Communities Coalition. I think that there's a little reluctance with emergency medicine because we don't see ourselves as being managers of long-term illness like this. I don't start many people on statins for their high cholesterol. It's rare that I'll start a blood pressure medication in the ED. But it really does make sense that we should be the ones to at least get them down the pathway. But you have a heart attack, you go home with an aspirin every day, you're on a beta blocker, you're on a statin. If you come in with an overdose, you probably should be started on, whatever your medication-assisted treatment that's appropriate for you is and the best one for you.
Unlike other addictions, opioid addiction actually has the benefit of multiple medications that can be used to assist you in the recovery process.
Medications for opioid addiction reduce mortality by half. This is incredible. Very few medications and treatments do that. We have 3 FDA-approved medications to treat opioid addiction. It's buprenorphine, methadone, and naltrexone.
We've learned that the situation of being addicted to a substance, and perhaps particularly being in withdrawal, is really quite horrible. And to expect someone just to go through that when they know there's immediate relief available just simply makes no sense. I'm Dr. Randall Brown. I'm an associate professor in the Department of Family Medicine and Community Health at the University of Wisconsin. I'm the director for the Center of Addictive Disorders at UW Hospital and the director of our Addiction Medicine Fellowship Training Program.
Buprenorphine is a great medicine to start at that time point because it treats withdrawal and it treats their addiction.
And it kind of stabilizes people so that they can lead a normal life. And people say, oh, well, it's not, buprenorphine is just another opioid, but it buys people time, and that's the thing. And if you can buy them, for sure if you don't use it that they're at risk for dying. And if they use it, then maybe they can get into treatment. And it might not be all the time, but what if it's a 50% chance or a 20% chance? That's better than a 0% chance. Hi, I'm Tim Westlake. I'm an emergency physician. I practice in Oconomowoc, Wisconsin. I'm a member of the Controlled Substance Board for the state and the vice chairman of the Wisconsin Medical Examining Board, and have served as the physician architect of the opioid reform strategy for the state. So there's a long-acting medication called Vivitrol, which actually completely binds and blocks any effect of opioids, and that's an injection that's done. That's really good in corrections, where people it gives them a chance where even if they wanted or if they tried to use and get high, they couldn't. Those two are very excellent excellent medication-assisted treatment regimens. Both very effective clinically. Studies have proven that they are effective and they do help with sobriety, maintaining sobriety and recovery.
Far too few people have access to these medications. So it is our goal and our hope that more patients will be able to receive this appropriate evidence-based treatment because it will help them achieve remission and enter recovery, but also on the flip side will prevent death.
I think one of the main things we can do as emergency physicians, as someone that's just resuscitated someone, is to give them the tools so that they don't need to use again. If you know, I see people, I resuscitate them, and I know that they're literally on their phone planning their next. They're going to stop at their dealer's house on the way home to pick up the next use of the opioid. So I think one thing we can do is if we can get them medication-assisted treatment, if we can induce them on Suboxone or buprenorphine, then you can stop that craving, and you might be able to buy them time to get them into treatment. I know for sure, you know, if you don't get them in medication-assisted treatment, they will be using within a matter of hours of leaving.
One of the things I hear from my patients and their family is that, boy, you know, I would intervene if he hit rock bottom, right? That the patient needs to hit rock bottom, that's an absolute myth. What, do you want him to be dead? That's rock bottom. We don't want that. Early initiation of therapy, that's really what's needed.
What we really need to do is get people to completely forget about this idea that you have to hit rock bottom in order for treatment to work or treatment to be initiated. That's crazy. You do not ask people to completely have heart failure to deal with your heart. It's the first sign of angina. Okay? You don't wait for the muscle to be damaged. You just have the first sign of low oxygen to the heart muscle. The first sign of stomach upset may be the first thing to find a stomach cancer. But you don't wait until the person's throwing up blood. But with addiction, we do wait, which is horrible. Physicians have been trained to recognize medical complications. And so we wait until the disease is so advanced that there's medical complications. That's wrong. We should intervene early. The earlier intervention, the better.
We should help them as soon as possible because the main risk of addiction, other than affecting professional and personal life and health, is also overdose. We do not want to wait for it.
And unlike diabetes and high blood pressure, where I have a number that I can say, aha, that's the disease you have, I don't have that with addiction. And it's really important that the patient and the family, frankly, is outside of the denial phase and ready to move on.
In the emergency department in particular, we have to be able to see where each of the patients are in their stage of addiction and the recovery process. And we have to try and meet them at that level where they are so that we can engage them in the healing process. There are some people who are in the pre-planning phase. They haven't really figured out that they have a problem. They haven't decided that they want to admit to it. They don't want to commit to treatment. So we have to be very subtle with them and try and put the pieces in place that they can use when they're ready. Then we have some people who are in the planning phase. They've recognized that there's a problem. They're starting to turn for help. Then we'll have people who are in recovery, which lasts anywhere from a short period to a very, very long window, depending on the individual. And then unfortunately, the last phase is the relapse, which can happen at times. And so for the recovery people, you know, it's always important for us to try and support them and be positive and reinforce their good behaviors. And then in the relapse phase, we have to try to re-engage them in the process, encourage them to continue, not get discouraged, not give up on themselves, because those people are definitely at risk of backsliding into the first two phases if we don't help them.
One of the things that I've experienced in the 30 years I've been in emergency medicine is that the frustration that not knowing what to do. So someone comes in, they overdose, and you just kind of like, good luck, and here's something to follow up in 2 weeks. I think what we have now is the ability to use induction of medication-assisted treatment and give them that bridge that will get them so that they can get into recovery and can get into treatment.
They aren't not in recovery because they don't like you or they don't like your message or they have a personal problem with you as an individual. It's more because it's the disease process and the way the person is coping with it and working through it. They just haven't gotten there yet. And they will get there at some point. You just don't know. And everybody's different. I don't know if it's going to be the first time that you have an overdose and come in that you're going to recognize it, or if it's the 5th time, or if it's the 10th time. Whatever it is, all I can do is continue to meet you as a person, to encourage you to keep working through that process and then give you all the tools that I can so that when you walk out the door, when you're ready to accept them, I've already armed you to the best of my ability to get started on that road to recovery.
There are ways that we as clinicians, but also as family members, can promote a person's entry into an engagement in treatment. So from the clinician side, being non-judgmental, presenting facts rather than opinions, and accepting the person in front of us as they are, because they have a disease of addiction.
The substance use field has really operated in isolation historically and has not been thought of as part of mainstream medicine, and that just needs to go away. I mean, this all needs to be part and parcel with how other chronic illnesses are addressed, and general health care needs to be part of that in addition to specialist treatment. And they need to be able to communicate.
Whoever has addiction for life, but just like diabetes or depression or hypertension, it could be really well managed, and people can live full lives, professionally, personally, and happy lives despite addiction, assuming it's well managed. However, if it's not treated, not appropriately managed or adequately managed, then addiction can consume one's life, because the main feature of addiction is loss of control.
Let's deal with it like a chronic disease. Let's manage it over time like diabetes, hypertension, and major depression, and not feel like we can do an acute intervention like, let's pick 28 days, and think that's going to be curative, because it's not.
It's not just the patient, it's their family, it's their whole support system, it's their primary care doctor as an outpatient. It's having access, again, to both behavioral and medication options to help maintain their recovery.